Hi guys, welcome back to the channel. We have started with ameloblastic fibrosarcoma. We have dealt with the introduction, what is it is. Now starting the clinical presentation. Okay, let's start. Okay. Occurs 20 to 30 years later than ameloblastic fibroma with a peak incidence at 30 to 40 years. Okay, it occurs after 20 to 30 years of ameloblastic fibroma and the peak incidence is at 30 to 40 years. Some arise from a pre-existing ameloblastic fibroma, others some to arise de novo as an ameloblastic fibrosarcoma. Okay. कोई ट्यूमर ऑलरेडी जो अमीलोब्लास्टिक फाइब्रोमा प्रेजेंट है उससे मैलिग्नेंट ट्रांसफॉर्मेशन करते हैं और कोई एज मैलिग्नेंट ट्यूमर यानी एज अमीलोब्लास्टिक फाइब्रोसार्कोमा अराइज करते हैं. It present as a multilocular radiolucent lesion causing jaw expansion. As a malignant tumor, it is capable of neural invasion and may therefore include paresthesia in its presentation. Obviously, it shows neural invasion, so it can cause paresthesia. Neural invasion क्यों है? Because it is a malignant tumor. Even though the tumor is malignant, its low-grade nature produces only slow growth with little tendency to ulcerate overlying mucosa. Even though the tumor is malignant, it is a low-grade tumor. We have seen it is a low-grade malignancy, so it produces only slow growth with a little tendency to ulcerate overlying mucosa. The malignant component of the ameloblastic fibrosarcoma is the fibroma, arising from the primitive odontogenic mesenchyme of dental papilla and de novo malignant expression from a genetic alteration of this mesenchyme. Okay, so we know that there are two components, epithelial and the fibrous component or mesenchyme or ectomesenchyme component. So the malignant component is mesenchymal component, not the epithelial component. So it is the fibroma which causes malignant transformation, or it is the fibroma which shows gene alteration. Okay. Now differential diagnosis. Okay, see, ameloblastoma, odontogenic myxoma, central giant cell tumor, primary intraosseous carcinoma or central mucoepidermoid carcinoma. Okay, this can be considered as differential diagnosis if paresthesia is there. If paresthesia is not there, these are the differential diagnosis for ameloblastic fibrosarcoma. Now, diagnostic workup, incisional biopsy deal with the lesion from a mid-crestal approach. Once malignancy is diagnosed, a CT scan for determining the stents and chest X-ray is required. Okay, chest X-ray to see if there is any metastasis to the distant organ or not, for the distant metastasis. Okay, histopathologically, it resembles ameloblastic fibroma. Epithelial nest as a benign component, mesenchymal component is malignant, I told you before, demonstrated by hypercellularity, pleomorphism, mitosis and infiltration. These are all the characteristics of malignancy. Now treatment. Best treated with resection using 1 to 1.5 cm bony margin and one uninvolved anatomical barrier. Obviously, as it is a malignant tumor, we have to go for resection. Continuity defect in mandible is best managed by a rigid reconstruction plate initially and followed by staged bone grafting. Reconstruction plate and bone grafting. In maxilla, the surgery is usually a submucosal partial maxillary resection resulting in a central defect over which mucosa may be closed and a denture like splint support may be placed. If it occurs in maxilla, then partial maxillary resection is there and the defect is closed using mucosa and we give a splint-like denture or denture-like splint. Okay. Radiotherapy is of little value in this tumor, but chemotherapy can be considered as an urgent therapy. Chemotherapy is considered an urgent therapy after dissection or after the surgical intervention. Prognosis good when treated with surgical resection. Obviously, it is a malignant tumor. We have to go for surgical resection, then reconstruction, and then bone grafting. This is the treatment protocol for any malignant tumor. Okay, follow up must be prolonged. Why? Because it is a slow growing tumor. तो follow up हमेशा लंबा समय का होना चाहिए, लंबा होना चाहिए. Okay, so we have finished with mixed odontogenic tumor by finishing ameloblastic fibrosarcoma. Next class will be starting with mesenchymal odontogenic tumor. Okay, we have finished epithelial, we have finished mixed. Now we'll be starting with mesenchymal odontogenic tumor in next class. Till then, like, share, subscribe and comment. Bye.